Hello, my name is Hannah Hinckley, and this is my topical presentation for Nursing 535, Concepts in Neonatal Nursing, and I'll be presenting today about developmental care in the NICU. So the contents of my presentation include what is developmental care, why it's important, and how we implement developmental care in our nursing practice. So developmental care is principles in infant care that facilitate emotional, physical, cognitive, motor, and social development of the neonate. The two areas of caregiving that we focus on are the environment and caregiver interactions, and this has to do with both how the nurse and family interacts with the neonate. The four principles that we abide by are promoting safety, calm and comfort, connectedness, and self-empowerment for both the patient and the family. So the importance of developmental care is that even being admitted to the NICU is an adverse childhood experience, or an ACE. This is because it creates a situation where there's sympathetic overdrive or overstimulation of the hypothalamic pituitary adrenal axis, which leads to toxic stress, and that can have negative long-term outcomes through the inflammation and catecholamine release, as well as there's a separation of the parent-child dyad, which disrupts the co-regulation that would occur with a typical post-birth process. So short-term complications of this unmanaged stress are going to be difficulty with ventilator weaning, increased infection and skin breakdown risk, inadequate feeding and nutrition due to oral aversion and other factors, and longer NICU stays. And then with developmental care, we can improve neurodevelopmental outcomes, social connection, parent sensitivity to the child's needs, and nervous system regulation of both the parent and the neonate. So now we're going to go into how we implement developmental care into a nursing practice. The elements of developmental care include fostering a healing environment through bed space design and protected sleep, promoting developmental care as we provide care, just normal activities of daily living care, like feeding and mobility and positioning, promoting language development through talking, reading, and singing, and educating parents on how to do the same, and ensuring that all our care is family-centered. So we're promoting bonding and empowering the families in creating autonomy, allowing them to do as much care as possible, and collaborating with them as much as possible as well. And then using techniques for pain and stress management, such as positive touch and non-nutritive sucking, as well as facilitated tucking. So to create a healing environment, bed space design is really important. So we want to position, obviously, the equipment for easy access to the infant in case of emergency. We want to have a comfortable chair for the family, maybe offer pillows and blankets, and encourage them to make the space their own, hang out decorations. Maybe we take some pictures and print them out, create some posters and signs, allow them to bring stuff from home, like stuffed animals. We also want to protect infant sleep, so this might look like providing no non-essential care between 2300 and 0500. That's 11 p.m. to 5 a.m. Cue-based clustered care, so we always cluster care in the NICU, having touch times, but also assessing infant cues using the stoplight model, which I will go over. It looks like light cycling, so ensuring that we have the lights darker at nighttime, and then when appropriate, really around like the 32-week mark, we start to keep the room lighter. In the daytime, maybe older infants would be put near the windows to help their circadian rhythms adjust so that sleep training is easier before discharge. We want to minimize sounds and odors. So there's a lot of alarms that go off in the NICU. So silencing monitors and alarms and paying attention to those, as well as speaking quietly, especially with neonates under about 32 to 35 weeks. Beyond 35 weeks, you might speak in a normal tone during the day to help with their language development. But when they're younger than that, you really want to make sure you're speaking in a hushed tone, so you're not irritating them, and encouraging family members and other members of the care team to do the same, as well as minimizing noxious odors, so hairspray, perfume, educating the family to avoid those as well. If anyone smokes cigarettes, telling them to change their clothes or to avoid smoking cigarettes close to coming into the NICU. And then ways that we can help the infants go to sleep is bathing them before bed and swaddling them, maybe doing some facilitated tucking, and taking deep breaths with our hands on them for nervous system regulation before they go to bed. So the ways we incorporate developmental care into activities of daily living, into touch times, is that we want to approach them with intention. So don't just walk up and immediately start, undressing them. You want to let them know you're there, introduce your presence, maybe softly speak to them or gently touch them first and assess their cues. See where they're at, see if they seem regulated. Also, it's something we'll have to chart, what state they were in. So just always assessing that. Promoting oral feeding, so positive oral stimulation. Maybe if they're not ready for having a bottle, non-nutritive sucking with putting a little breast milk on the end of a pacifier and promoting their sucking reflex that way. And when they do start to take bottles, it's about quality over quantity. So the amount of feed that they get by mouth is not as important as how coordinated their suck, swallow, breathe reflex was during that process. We promote that by using a slow flow nipple, pausing frequently, like every 3 or 4 sucks. Keep your hand on their back and ensure that they're breathing between every 3 or 4 sucks, and then collaborating with the speech-language pathologist on that as well. And then we want to promote early mobility as well, so developmentally appropriate movement. It might look like, bicycling their legs or moving their arms around a little bit, stretch, if appropriate, if they're older. And we can collaborate with PT on this as well to maybe they favor looking to one side, so using positioning aids like gel pillows to make sure they look to the other side to prevent torticollis or any excessive flattening of the skull. And then this is the stoplight model I referenced earlier for assessing infant cues. So we know that they're ready to receive care, to hear your voice, and to maybe to do some of the mobility stuff. They're ready to try eating by mouth if they have a stable heart rate, good even color, even respirations. They look relaxed and have a flexed posture. They have smooth movements. Maybe they're grasping with their hands or they're putting their hand to mouth. And they have bright-eyed stare and they're looking at you and making eye contact. You might want to pause and help them regulate if you see anything in this column, so mild tachycardia, heart rate drops, maybe there's an increased work of breathing, mild retractions, mottling or paling or acrocyanosis, if they have a couple hiccups, if they look kind of tense or their fingers are splayed or their extremities are extended or they look kind of jittery, or if they're averting their eyes or they look really hyper alert or they have consolable crying. You just take a minute and help them regulate, see if it seems like they're ready for developmental care. And then we're going to stop and do some interventions if they have any bradycardia or tachycardia, extreme redness or pallor, moderate or severe increase in work of breathing, if they are vomiting or gagging or retching, they have a vigorous hiccups, that means that their nervous system is overstimulated, so maybe stop feeding them if they're hiccuping a lot. if they have a stiff body or they're arching their back, or if they look really flaccid or limp. And then if they're crying inconsolably or really difficult to arouse, try a few nursing interventions, and then if they're not working, you're going to want to get some help from other members of the interdisciplinary care team, depending on what's going on. Positioning in the NICU is very important. We want to do frequent position changes, monitor their position, see, if they're rolling back over, or see if they're in the same position you left them in, promoting tummy time, supervised, making sure their positioning is symmetrical and they have neutral alignment. So supporting with props, like I mentioned, gel pillows, rolled blankets, doing slow movement transitions, so don't be too abrupt with that. Avoiding hip abduction or restriction, so assessing their diaper size and placement. And if it looks like their hips are abducted, you can pinch the part of the diaper that goes between their legs so that it's not keeping their hips splayed out. We also want to make sure when we're swaddling that we're creating space for their lower extremities to move and not restricting any movement there. Also, to keep them flexed which is optimal position for them, you can use the frog sandbags. That's also comforting for them, or a little snuggle up thing. And then there's also patient-specific positioning depending on, what's going on with them. So if they're mechanically ventilated, you want to keep them prone frequently, elevate the head of the bed to prevent aspiration. If they have gastroesophageal reflux, keep them prone or on their left side following feeds. And if they have a lot of residuals, then keep them prone or on their right side following feeds to promote absorption. To help with their language development, you can use the model developed by Susan Brasher called Talk With Me Baby. The 3 elements are to narrate your day, so just explaining what you're doing. Parentese, so that's about kind of the inflection of your voice. Speaking gently, maybe in a slightly higher pitch, in a way that's engaging for infants. And then there's serve and return. So if they're cooing at you, acknowledging that, like, oh, tell me more about that. And then reading or singing to them. So there's a lot of books on the unit encouraging parents to read to them and just exposing them to as much language as possible, especially if they're over 35 weeks. So to promote patient and family-centered care, we really want to encourage bonding through things like skin-to-skin care. So that's kangaroo care, just placing infant on a bare chest, baby wearing, if that's accessible, and if the infant is stable. You can use mirrors if they're breastfeeding so that they can see the latch. And ideally, you're going to have skin-to-skin care for 90 minutes 4 times a week. That's the goal there. Another way to promote bonding is through scent exchange, so you can give any parent a little fabric square that they'll put in their shirt and maybe wear overnight and then bring back, and you can put it near the infant so that they have that comforting scent of their parent with them. Also encouraging parents and family members to do as much as possible. So you can use the I do, we do, you do approach, where you first demonstrate, then you encourage them to take over and do it, but with supervision and help from you. And then when they're comfortable, they're kind of on their own with things like taking temperature, changing diapers. Allowing unrestricted access as much as possible, following facility guidelines. Some NICUs don't allow parents to be in the rooms during shift change and stuff, but for the most part, just creating a really welcoming and supportive environment, telling them you're glad they're here, don't make them feel like a nuisance or like they're in your way, orient them to the room and the unit and all the equipment in the room. So it can be really intimidating if you don't really know about NICU equipment or what a NICU is the first couple times a parent comes to visit, just ensuring you're explaining what all the different tubes and wires and noisy machines are doing. Explaining that an alarm going off doesn't necessarily mean it's an emergency, it's just, and explaining kind of the parameters around that. and the specific numbers so that they know what all the numbers on the screen mean. And collaborating with families, using a shared decision-making model, educating and consulting with them, soliciting their goals and writing those on a whiteboard so that you know what's most important to the family, and engaging them in care, so promoting autonomy, like I mentioned, call and FaceTime them with updates, even if something as simple as we are now giving the baby a few more milliliters per feed. That might be something the parent wants you to call and update them about. If they are on a different type of ventilatory support, call and let them know. You don't want them to come in. If you move them into a different bed space, let them know you don't want them to come in and not be able to find their baby. That's scary for them. And then some other things we can do to promote pain and stress management that are non-pharmacologic, because of course we have different pain medications, are teaching parents about techniques such as facilitated tucking or giving the baby a hand hug. So that's where you put one hand on their stomach or kind of flex their feet in or their legs in, and one hand on their head. Take a few deep breaths with them. It's also just called static containment. And being gentle but firm with this, and this is really the preferred type of touch, especially for when they're below 32 weeks, is static touch. You don't want to do too much of that stroking. I know a lot of parents want to just do like the really gentle stroke, but that can really be more irritating than anything to the infant. So also educating the parents on the stoplight model. If she's putting her hands up in her face, or if the infant is putting hands up in their face, that means that they might be more irritated by that kind of touch than anything. Obviously managing their temperature, so avoiding cold or heat stress, making sure they have an appropriate amount of layers on for what their bed environment is, monitoring their temperature regularly, adjusting the set temp of the bed, and then using other pain and stress buffers like non-nutritive sucking during any type of procedure. You can put the sweetums or sucrose on there if they're not too young. Using a buzzy bee, which is like a little device that kind of vibrates, and you can use that anytime you're going to do a needle stick or a heel stick, and that's kind of the idea there, is that it disrupts the pain signal. And that can be used for children of any age as well. And then that soothing touch I mentioned is appropriate if they're older than kind of 32 to 35 weeks, depending on their stage of development. So that could look like, massaging their head and extremities, anywhere that they might get IV sticks to kind of counteract that negative input. Positive touch around their face and mouth to counteract the negative input from the airway devices and enteral feeding tubes. So like I talked about, the non-nutritive sucking. And then as well as kind of massaging their little feet and heels, because they got a lot of heel sticks and you want to counteract that negative input as well. But watching for cues of overstimulation as you do this. And then also coordinating with parents so that they can be present during those painful procedures, and really just holding their hand every step of the way. This is a really scary time for them. We want to have a shift from thinking about the NICU as just the neonatal intensive care unit to more of like the newborn intensive parenting unit. We want parents to feel so ready to take that little guy home upon discharge, and that means educating them as much as possible and involving them in care. So here's my references, and thank you for listening to my presentation.